Okay, folks. Let's go on to our next session. It's great to see that we still have a lot of people here. That's excellent. I have the privilege of introducing our next speaker. Andy Hebert has worked as a PA. Sorry, did I win? Andy Herber has worked as a PA at Mayo Clinic in the Division of Hospital Medicine for 17 years. In addition to seeing patients, Andy serves as the chair of the NPPA education for the institution. He is a course director of 3 NPPA hospital medicine CME courses and is a well-known national speaker. He is faculty at the Mayo Clinic Simulation Center, as well as he lectures to local PA and NP programs. Andy is an active preceptor for PA students and has received multiple education awards in his career. Thank you, Andy, for being here, and let's give him a warm round of applause to welcome him. Yeah.
All right, how's it going? Good. All right, thanks for the introduction. Yes, it's Herber, very Midwestern American pronunciation, H-E-R-B-E-R. So thanks everyone for coming back and attending the presentation. This presentation is Electrolytes on Wall Street. Prior to PA school, I worked in the lab, and now I work as a hospitalist. So this is a combination, kind of a hybrid of the two, and how do you interpret labs in the hospital setting. I have nothing to disclose, but I'll take money. You can write me a check, give me cash. I have Venmo. The other disclosure is I am American, so if I say anything, just keep that in mind. So here's the census. These are the patients we're going to be taking care of: Mr. Millennial, Mrs. Salty, Mr. Farmer, Mrs. Khaleesi, and Mr. Sweaty. So these are our patients. Obviously, I've changed their names and exaggerated a few things here and there for educational purposes. You guys have my handouts. I know there's probably an updated version that'll probably be uploaded soon, but my recommendation would be to just sit back. There's a lot of audience response in this presentation. And if you guys just want to yell out answers or raise hands, I feel like that's the best way to learn. I know a lot of people want to write. I talk really fast. I've had a lot of coffee this morning, so I'll probably talk even faster, but it probably, from an educational standpoint, if you just sit back and participate and take care of these patients with me, you're going to learn the most. So let's get started. First patient, Mr. Millennial, 24 years old, unknown past past surgical, and medications. He's dropped off at our emergency room at St. Mary's Hospital in Rochester, Minnesota. He's sweating profusely, complaining about his girlfriend, Molly. He's tachycardic to 112, he's febrile to 39, and he's hypertensive 160/80. Here's his labs. And I did my best to switch from American values to Canadian values. I may have missed one here or there, so if you see any mistakes, just let me know. But I just want you to focus, obviously, on the red or the abnormal. So a little bit of leukocytosis, obviously some hyponatremia there, a little bit of hyperglycemia, but otherwise everything else kind of looks okay. So he's hanging out, he gets admitted to our service. So of the following, he's down in the emergency room, what's the next best order? Give this guy buckets of normal saline, give him some lactated ringer, give him dexamethasone, obtain a urine sodium, give him a lumbar puncture, empiric antibiotics and antivirals because this is meningitis, or you serve him up a bowl of PF Chang, hot and sour. Do you guys have PF Chang? No, it's like pure salt. It's like 9 grams in that order itself. And then you add the bag of pretzels too. So what do you guys want to do here? Again, hyponatremia, tachycardic, febrile. I heard some C. All right. So whatever you guys want to do on the internal medicine floor, it doesn't matter because the emergency room says, I like your idea, but you know what? Down here in the ER, we wear a bunch of Patagonia vests and we resuscitate with authority. So they crank up the normal saline and give this guy a couple liters of saline and admit him to medicine. So by the time Mr. Millennial gets on the floor, he starts seizing on the floor. So you get a stat sodium check on him and you realize that his sodium has gone from 120 now down to 118 despite 3 liters of normal saline. So he's having a seizure, and what do you want to do for him now? Lorazepam, 3% saline, normal saline, and AMPA D50, 1 and 2, 1 and 3, 1 and 4, none of the above. 1 and 2 is fantastic, right? So we need to stop the seizure and then we need to stop the underlying cause. If we just give benzos right here, he's going to continue to seize because his hyponatremia is driving this. And so we need to fix the hyponatremia. And the best way to do that is with 3% saline. So you're absolutely right. So on repeat labs, you see that his sodium is 121. You've corrected that. And then now I'm starting to unblind some of the other labs that maybe we would have drawn on admission. So his urine sodium is 58, his serum osmo is 250. My question for you now is, he's stable, he's hanging out on the floor, is now what do you want to do? You want to back him back up, a little bit of furosemide IV? Do you want to give him, now is the time to give him some dexamethasone? Does he need IV levothyroxine? Now do we give him normal saline, or do we check his iPhone? Remember his age. What's that? Yeah, that's a good idea. But you do check his iPhone because he's a young kid and you're able to hack into him. And this is what you see, like all his most recent pictures. This is a big time rave. So he's hanging out at a rave and he had taken a bunch of ecstasy. And so ecstasy's probably fallen out of favor, at least in the United States. Unfortunately, fentanyl has kind of taken over as to what people are using, but ecstasy's still out there a little bit. And ecstasy releases norepinephrine and dopamine. It causes hypertension, hyperthermia, tachycardia, all those things that he presented with. Its peak effect is about 2 hours after ingestion and lasts about 4 to 6 hours. It causes hyponatremia from a combination of 2 reasons. One is SIADH, and then 2, a lot of these kids that are taking it, or adults, get real thirsty. They drink a lot of free water. So they're not drinking Gatorade or more alcohol or lemonade or something like that. They're just grabbing Aquafinas or 20 ounces of water. And so they're actually diluting out that sodium further. And then remember, if they're ingesting ecstasy, what else do they have? So make sure you kind of run your ABCs, think about co-ingestions, obviously make sure their respiratory status is okay. And again, down in the United States, and I'm not so sure how prevalent it is up here, but fentanyl is a big one. All right, so for Mr. Millennial, we fluid restricted him overnight. His sodium improved to 125 the following morning. We had chemical dependency come and see him. We were discharged him home with his mom, and then he broke up with Molly. So you guys know Molly is the street name for methamphetamines or ecstasy. And so he was complaining about Molly on admission in the emergency room, which we thought was his girlfriend. Turns out it was those darn drugs he was taking. All right. So hyponatremia, I could talk about hyponatremia for hours and hours and hours and hours. It's the most common electrolyte disorder in hospitalized patients. Probably up to, 10–20% of my patients that I'm taking care of in the hospital are going to have hyponatremia. And everyone always sees hyponatremia and they're like, I'll learn about it real quick here, and then I'm going to forget about it. And then next time it comes up, I'm going to try to crash course it. But I'm going to hopefully walk you through kind of a poor man's hospital medicine approach to hyponatremia and hopefully get you through it. But when you think about hyponatremia, I think, obviously the focus is on what's the sodium, but then just remember, follow the water. So is the patient hypovolemic? Have they just been sweating? Have they just ran a marathon? Are they euvolemic? So that's your SIADH, your adrenal failure. So the patient has hypotension, hyperkalemia, hyponatremia. Think about adrenal failure there, especially if the patient's been on prednisone or something like that over the last couple of days. And then hypothyroidism. Is the patient hypervolemic? These patients usually tell you that they're wet, they're hypoxic, they got heart failure, they got a big belly, they got ascites. Those patients are easy to tell. And then you can get pseudo hyponatremia, and that typically comes from hyperglycemia, hypertriglyceridemia, or hyperparaproteinemia. And again, these slides will be all available for you. I know a lot of people are trying to kind of write some things down. But when you talk about workup, this is up to date type of thing. You guys have all seen kind of this box, if this, do this, if that, do that, and you kind of follow it along. But really, when you think about hyponatremia, if you just kind of boil it down to real kind of basics, this will work a lot of the times, or at least help you in the position where you're not making that call to give somebody with SIADH a whole bunch of fluids in the emergency room, like what just happened to Mr. Millennial. So first you want to think about what's the serum osmo. And I would say like 95 to 99% of the time, it's going to be low. You're usually going to be dealing with a hypotonic hyponatremia. And then the next thing you want to know is what's the patient's volume status. So it's really easy when the patient's hypotensive, they're tachycardic, they told you they just had norovirus for the last week, they're on diuretics, they've been puking. Those patients are going to tell you that they're hypovolemic and they're going to benefit from fluids. The tough ones are the ones that come in like Mr. Millennial, who doesn't quite look like he's hypovolemic. So those are the ones that you really need to take a break on, because as you see, what we did to Mr. Millennial in the beginning was we just gave him a bunch of saline because the sodium was low, and that actually caused harm. And then the last thing I would suggest is just get a spot urine sodium. It can help with your decision making, and we'll talk about that in a little bit here. But if you look at his admission labs again, so this is when he showed up, remember, tachycardic, hypertensive, and febrile. So his sodium is 120 and his urine sodium is 58. That's kind of a mismatch there. So when you think about interpreting a spot urine sodium on a patient, if your serum sodium is low, you should tell your body, don't pee out salt. So your urine sodium should reflect that. It should be low as well. That tells you the patient's dehydrated and they're going to benefit from saline. The contrary to that is if their patient's serum sodium is low and they're peeing out a ton of salt, so their urine sodium is 58 or 100 or 300 or 400, that's a mismatch there. That means you need to think a little bit more about SIADH. And in that situation, you cannot give more saline. You can't expand that fluid volume or expand that plasma volume, because if you do, you secrete more antidiuretic hormone, hold in more free water, and that sodium of 120 will drop to 118. Now, I'm not saying that everyone that comes in with hyponatremia that you give a little bit of normal saline to is going to seize. Obviously, I've done some of this a little bit for exaggeration, educational purposes, but just know if it's SIADH, you do not treat that with normal saline. So when we talk about SIADH, things that cause SIADH, it's usually malignancy, and a lot of times it's in the lungs or in the brain tends to trigger that. Anything in the chest, does the patient have pneumonia? Do they have a pneumothorax? Do they have lung cancer, especially small cell lung cancer? Anything in the brain, like we talked about, some drugs, antipsychotics, antidepressants, SSRIs are huge here. And it's not like the day after you start an SSRI, it's typically about 2 weeks after starting one is when you're going to see that drop. And it's unlikely that a patient who's been on an SSRI for years is all of a sudden going to spontaneously get hyponatremia from it. And then miscellaneous things like pain and nausea and postoperative status, a lot of things that we see in the hospital can cause it as well. When you're diagnosing SIADH, again, this is in your charts and your handouts for review here, but just make sure you have all these boxes checked. When you're talking about how do you manage or how do you treat hyponatremia, if it's volume contraction and you're sure of it, so again, patient's tachycardic, they're hypotensive, you pinch their skin, it sticks up for a long period of time, they got like white caked mucous membranes, they just ran a marathon, they just told you their doctor increased their furosemide dose, or they had a bad viral illness. Those patients are going to benefit from normal saline. You can give them salt water. Their urine sodium is probably going to be low or at least less than 10. But if it's SIADH, you want to treat those patients with fluid restriction. We only use 3% if the patient is really in neurologic emergency type of thing. So if they're not seizing, you have time. A little bit of altered mental status or confusion, you still have time, and we don't necessarily need to grab that bag of normal saline. I'm sorry, 3%, because if you guys remember, the sodium equivalent in normal saline is 154, and then in 3% is 513. So when we talk about correcting sodium, we want to go slow. If the patient had a hyponatremia very fast, you're probably going to get away with correcting them very fast if you do accidentally. But if it's been a slow onset and you correct fast, you're going to get into a lot of trouble. So take your time. Again, make sure you get them out of that 120 is kind of your seizure threshold. Some patients are going to tolerate a lot lower. I just took care of a patient 2 weeks ago that was 103, and he's just hanging out, watching TV in the room. So patients don't always read the books, but right around 120 is when I start getting nervous about seizures. And then obviously the correction, if it happened fast, you can probably get away with correcting it fast. But if it's been a slow thing, then you want to take your time, because you want to worry about osmotic demyelination and fatal herniation of the brain, locked-in syndrome, which is catastrophic. All right, guys, good? That's hyponatremia in like 5 minutes. I'll get to questions afterwards if that's cool. Yep. Here's our next patient. This is Mrs. Salty. Mrs. Salty, Caucasian, 80-some-year-old female, lives in a nice retirement community. She's got coronary artery disease. She's had some cataracts taken away. She's single, doesn't smoke, doesn't drink. She's only on aspirin 325. She's been nauseous, been vomiting. She's been orthostatic. Everybody else that she plays cards with also has the same symptoms. But she was telling one of her neighbors that she vomited this morning, and she thought it was kind of dark colored. And her friend is a retired nurse and said, if it's dark colored, you should go to the emergency room. So she did. She showed up in the emergency room, and her hemoglobin was 133 about 3 months ago, now down to 68. Pretty big swing there, but her sodium is pretty high. Her chloride is pretty high. Her potassium is a little low, but otherwise everything else looks okay. So one episode of vomiting, kind of dark colored. Her friends urged her to come in. Vital signs are stable. Again, our lovely emergency room said, hey, that's a low hemoglobin patient, probably has an upper GI bleed. So here's a unit of packed red blood cells, and we're going to send her up to you to take care of her. So the next morning, you're getting her ready for her EGD that was ordered, and you realize a pretty big swing in her labs. So hemoglobin 133 to 61 to 126 after 1 unit of blood. Her platelets are all over the board. Her sodium kind of bouncing around, as is the chloride. My question to you is, what's the most important next step for her care? Does she need an MRI because that sodium is swinging so fast? Are we worried about that low potassium of 3.1 that we should get an EKG and start replacing that? Does she need the EGD that the ER said she needs to be admitted for? Should we obtain H. pylori serology and see if she's got an ulcer brewing from that? Or should we fire the phlebotomist? Anybody want to take a guess? What's that? Platelets. I would argue here, and I used to do phlebotomy, so I can make this joke, but I would argue the phlebotomist needs to be fired. And I'll show you what's going on here. But this is a drip arm. If we go back, look at these labs and look at this swing here. So again, I work in patient medicine. What we're seeing in America, I'm sure you guys are seeing here as well, where we've had tons of burnout in the hospital, tons of people quitting, and we've been hiring people fast and getting them through orientation, and people are cutting corners and nobody cares anymore. Probably a little bit worse in America for that part. But, these are things that we're seeing. And so the education just isn't there. People are coming out of the pandemic. So what happened here is this phlebotomist drew from the antecubital fossa from a patient who had normal saline running in the hand on the same arm. So if you're going fast and you come to draw blood, whatever you're running into the hand vein, if you draw upstream from that, you're going to mix 50. I mean, it's not going to be 50-50, but it's going to mix together. And so I would draw your attention to the swing here in these labs. And so down in the emergency room, we saw that pretty big swing of hemoglobin there, and a patient that's otherwise stable, who essentially walked into the ER with normal vital signs. I would expect her to be short of breath, hypotensive, or something like that. But what really draws my attention, or kind of what I'm really focusing on there, is this chloride jump to 120 or 119. That's pretty high, especially if somebody that hasn't been exposed. Usually when you see hyperchloremia, it's because of us. It's because we've left normal saline running on a hospitalized patient for a long period of time, and we've caused hyperchloremic metabolic acidosis. But she wasn't exposed to that. So how does that sodium, or how does that chloride get that high? And it's because it's mixed in with the saline that was running into her peripheral vein, into her hand. So just keep an eye on that. It happens in the hospital. It happens a lot more now than I remember it happening earlier in my career. But when you see hypernatremia, a lot of times it's going to be dehydration. The patient's going to benefit from free water, so D5 or lactated ringers, something with a lower sodium concentration. You can also get diabetes insipidus, neurogenic, and nephrogenic. But the tall tale here is the hyperchloremia. So it's hard to do that. It's hard to get hyperchloremia, especially if you've been outside of the hospital. And so a lot of times it's iatrogenic. So that's what would draw my attention. So this patient did not need that unit of blood. They did not need that EGD. So again, we do a lot in hospitalized patients, a lot of iatrogenic things that increase their risk. So what happens if they would have had a big trolley or transfusion-related acute lung injury to that unit of blood? What happens if they would have had a perf or complication from anesthesia from that EGD? So take the time, redraw the labs if they don't make sense. All right, here we go. This is Mr. Farmer. There's about 1 billion of these in Minnesota, where I'm from. And this is right around the time that this happens a ton of times. So this guy's never been to the doctor, doesn't believe in them, doesn't want to hear anything they have to say. He's married, doesn't smoke, doesn't drink. He's not on any medications. So Mr. Farmer, despite pleading from his family, again, this is like an 80-plus-year-old Caucasian gentleman with no past medical history, just because we don't know, and stubborn as can be. And he says, I'm not going to take, his family says, Dad, you need a cell phone. We need to be able to communicate with you when you're out in the field getting your crops in. He's like, I'm not taking a cell phone. I don't want anyone tracking me. I don't want anyone listening to me. And so he doesn't. So it's right around this time in Minnesota where the farmers are trying to get their crops in before the snow. And he's rushing a little bit and unfortunately hits a rock, flies off the tractor, lands on the ground, and then has immediate onset of hip pain. But as a farmer, very stubborn farmer, he still tried to like weasel his way back up into the tractor to finish the job. But unfortunately never was able to do that. So laid in the field for a couple hours. Finally, his family's like, where the heck is dad? He should have been back by now. They go out and check on him and they find him laying in the field and they call 911. He ends up getting a helicopter ride from one of the suburbs to Rochester, Minnesota. And he lands on the orthopedic service because he now has a broken hip. So when he shows up on the ortho team, you see that his hemoglobin is 117. His white cells are a little high, but otherwise everything else looks okay. You start him on a fentanyl PCA overnight. Guy uses not even a drop of it. He's on normal saline. You turn the Western movie channel on for him. He's asking, can he go home tomorrow? Because he's got crops to get in. And you're like, well, we'll see, buddy. So you come in the morning, the orthopedic surgeons are about to, whoops, I just noticed I made a mistake on that hemoglobin there. The orthopedic surgeons are coming in, they're like, all right, we're ready to take him. And you'd say, hold on, because his hemoglobin has drifted down a little bit, 117 to 101. His white count is kind of just bouncing around a little bit, but his creatinine has gone from 100 to 290. So you know that jump from like 100 or 1 to 2 or 100 to 200, that's a pretty big change. It's about 50% reduction in renal function. So, and that potassium of 7.3 makes me a little bit nervous as well. So we tell the orthopedic surgeons to hold off, which they're not excited about. But we obviously don't want to send somebody down to get their hip fixed. Despite their mortality increasing, we want to make sure that they have the best chance. And so my question to you is, now he has a AKI with a hyperkalemia to 7.3, is what's your next best plan for him? Stat EKG, repeat that as a plasma potassium. So it's just a serum potassium. If we repeat it as plasma, it's probably going to be normal. Give him IV Lasix or furosemide, check his urine eosinophils, or take all the bananas out of his room, which shouldn't be in there because he's MPO. I don't know who brought those in there. 1 and 2. Yeah, for sure 1, right? So we want to definitely get that stat EKG, and then repeating as a plasma potassium. You could argue you could do that or not. So when you think about serum potassium, a lot of times, or at least in the United States, these serums are, when we order like a complete metabolic panel or whatever, the blood clots. And so when you have clotted blood, the platelets actually release a little bit more potassium. So plasma is going to be a lot more correct or physiologically accurate as to what's going on. That doesn't mean that if it's serum potassium is 7.3, that the plasma potassium is going to be 4. So there's not going to be that big of a swing. The kind of teaching point as far as this is, if you're drawing plasma potassiums, stick with plasma potassiums. Don't go from electrolyte panel to plasma potassium, which is usually a stat potassium, then back to electrolyte panel, then back to plasma. Just stick with one so that you can appropriately take care of the patient. But if you get an EKG here, the T waves are flying off the chart. And obviously you guys know what's going on here. This is hyperkalemia. The EKG changes are what you would see there. My question is now, how do you manage hyperkalemia? So do you give this guy a little bit of saline? You give him calcium? Do you give him adenosine? Do you give him Caxlate? Do you give him furosemide? 2, yeah, right? So once you have EKG changes, you have to stop. You need to stabilize that cardiac membrane. So this patient needs to be transferred. They're not already on telemetry. They need to go to telemetry, and then they need some calcium. So calcium does what for potassium? Nothing. It's not going to help your potassium at all. All you're doing is buying yourself time, but this patient isn't going to go into some arrhythmia. So it's going to give you about a half hour for every gram of potassium you give. So you give this patient calcium gluconate or carbonate or whatever you have, you stabilize that cardiac membrane, you get them on telemetry, then you deal with the potassium. So what's going on here? This patient obviously has rhabdo, and that's the cause of it. So rhabdomyolysis, typically that's going to happen from crush syndrome or immobilization. So kind of what happened both here. So the patient fell off of his tractor, landed on his butt, broke his hip, and then laid on that muscle for a couple of hours. So he's got necrotic, anoxic muscle tissue that's breaking off and going through the kidneys and ripping those up. Other things that can cause it: marked exertion, hyperthermia, drugs, toxins, and infections. The infection I want to bring to your attention is influenza, because we're seeing a ton of it now. And I've started taking care of a lot of influenza A patients this last week. And so I'm sure it's coming here if it hasn't been here already, but this can also cause rhabdo as well. So anything else cause hyperkalemia? I'm just trying to figure out why the rest of that management kind of fell off here. So when we think about hyperkalemia, other things that cause it, typically decreased renal excretion, tissue catabolism, rhabdo, hemolysis. cell shifting, excessive intake, blood transfusions. That's the kind of, there's a lot of things here on this slide that you guys can obviously read and look at, and I don't need to read them to you, but I want to bring to your attention is every unit of blood that you order has live blood in it and then dead blood as well. So the blood's been in the refrigerator, then you say, hey, so-and-so needs a unit of blood, you order that up, that blood gets rocked back and forth, all those red blood cells are nice and potent with potassium, they break open a few of them, and then they release a bunch of potassium. So if you want to get high fives from the nephrologist in the hospital, you want to transfuse your dialysis patients during dialysis. Reason being is because they can manage for one, the volume, and two, the potassium that you're giving them. Obviously, sometimes clinical scenarios will dictate when you need to give that unit of blood, but it works a lot better on dialysis patients if you transfuse during dialysis. All right, so how do you fix hyperkalemia? And I apologize, some of the question slides fell off here as we work through. But this slide here breaks every single rule when it comes to PowerPoint presentations. There's way too much on the slide. There's way too small a print. So this is just a reference here. Nothing, I'm not going to go through every single one of these. But when we talk about managing hyperkalemia, at least in the hospital, the first thing you need to do is stabilize. So if you would have gotten an EKG and the patient has no EKG changes, you have tons of time, because the patient's not in dire straits then. So once you see EKG changes, the patient needs calcium, and you just need to figure out how you're going to get it in: calcium carbonate, calcium gluconate, and then that's going to buy you about a half hour to an hour, and then just make sure they're on telemetry so you know what you're doing. Once you stabilize calcium, you need to shift, once you stabilize it with calcium, you need to shift the potassium. And so a lot of times you use albuterol and insulin and D50. And so albuterol, this is a higher dose than just an albuterol nebulizer that you're using. But just keep in mind, so albuterol is a pretty significant beta agonist. So it comes on that, EK or hyperkalemia management protocol. But if the patient has an ischemic threshold of like 80 or 90, don't light them up with albuterol to correct their potassium. Use other means, because if you run their heart rate up in the 120s or 130s, now in addition to the hyperkalemia that you're managing, you're also going to be managing this heart attack. And so make sure you know where their coronary artery disease, whether or not they can tolerate a heart rate up that fast. If they can't, or you're not sure, skip the albuterol. And then insulin and D50. If the patient is non-diabetic and their blood sugar is okay, give an amp of D50 and then 10 units of regular insulin. And that's going to buy you about 6 hours. That's going to drive that potassium intracellularly. Remember, I'm spoiled. I work at Mayo, so I can get a patient down to dialysis and a line placed in them like that. And so if you can get the patient dialyzed that fast, you're going to really tick off a lot of people. If you say, hey, I know what to do here, I'm going to give insulin and D50, now they're ready to go for dialysis. Because what you just did is you took all the potassium that they wanted to dialyze off, you pushed it all back into the red cell. Now you got to wait 6 more hours to do dialysis so that you can actually clean the blood there and get that potassium off. So if you know you can get them to dialysis fast, which I can in Rochester, but probably not in a lot of other places, where you can get a central or a temporary dialysis line in, you can get a nephrologist, you can get that all organized, then don't manage it or don't temporize it if you can get them down to dialysis. If you need time, that's when you use these that's when they use these. Bicarbonate, I feel like that's fallen out of favor. We don't see that given quite a bit. And then when you talk about removing potassium, if obviously hemodialysis, which this guy needed just to run a hemodialysis, and then we needed to fix his hip, because every day you have a broken hip that doesn't get fixed, your mortality is going up by 50%. So you want to get that fixed. So he just needed to run a dialysis to stabilize the hyperkalemia, and then we were able to get him down for his hip fracture therapy. But otherwise, you can use furosemide. Not ideal in Mr. Farmer's case. This guy's got a progressive AKI, which is only going to get worse. But the patients, sometimes if they have heart failure and they have hyperkalemia, or if they have other options where sometimes you just give them a little bit of saline and then give them furosemide afterwards. Furosemide is a great way to get patients' potassium out, but you want to make sure that their kidneys are okay before you do that. We're talking about Lokelma, and I'm not sure if any of those medications you guys use are a formulary, but those are other, potassium binding, and then hemodialysis. What you don't Caxlate was like this go-to med that everybody loved to use for hyperkalemia. That's obviously fallen way out of favor. One is they compared Caxlate to a bunch of other meds. There's really no difference in how it worked. And so Caxlate, I know everyone thinks hyperkalemia give Caxlate, but it really doesn't work that much better than Miralax or Senna or anything like that. And then two, there's a lot of black box warnings on Caxlate that a lot of people probably don't know about. One is you can't give it to anybody who's perioperatively. Two, you can't give it to anybody that's on a renal transplant. And three, you can't give it to anybody who's on opioids. And so a ton of my hospitalized patients on opioids. And so the key is here, you don't want that KX-late. You need some gut mobility. You don't want KX-late sitting in the intestines waiting to be removed because that'll burn a hole in your gut. Thankfully, KX-late's no longer formulated in sorbitol like it used to be, because that sorbitol would burn holes in the intestines. But still, this patient, he's perioperative and he's on opioids, although he's not using them. So he's definitely not a candidate for a KX-late. I would avoid that. All right. Ready for the next one? Am I going too fast? All right, here's Miss Calacey. So Miss Calacey's obese. She's got a right total knee. She's single, wheelchair bound, resides in a skilled nursing facility. She's on a fentanyl patch and Miralax. She's confused, having back pain, and can't poop. And so her family has been complaining to the nursing home for a couple months now that her back has been hurting. And so it started with this Lidoderm patch, and then another Lidoderm patch, and then a fentanyl 12.5 patch, and then two fentanyl 12.5, and then a 25, and then a 70 or a 37. So when she got to us, she was really confused, constipated, had a bunch of patches on her back. But the family's like, something's going on with her. She's also losing weight. Can you guys take a look? So she showed up in our emergency room, and here's her admission lab. So she's got chronic anemia. Her creatinine, she's got an AKI, a little bit of azotemia. Her ALK phos is up pretty high, but otherwise everything else looks okay as far as like an altered mental status kind of quick workup, especially being an elderly female. UA was okay, the ABG was okay, she wasn't hypercarbic. So I'm not sure why. I think we did the wrong slide set. That's okay. So my question to you is, why does she have this, which I've already kind of showed, is going to be, these all kind of went out of order. So why does she have this, which ends up being hypercalcemia of malignancy? So she had metastatic breast cancer. So she had showed up, she had complained of low back pain, and had gotten, rather than anybody getting any imaging or doing any workup on her, nursing home patient, just kind of push it down, kick the can down the road, and had gotten patch after patch after patch, and then finally showed up with us. And if you look at these labs, the thing that would trigger me to think about this being hypercalcemia is the ALK phos being elevated there. So you guys are saying, hey, hold on, ALK phos, we know that that's a liver enzyme. But remember, ALK phos has 3 fractions. So bone, biliary, and placenta. Obviously, she's not of childbearing age, so it's not placental. And then bone or biliary elevation. I know it's probably not a biliary elevation because the bilirubin is normal, and then the ALT is normal. And another little lab hack is when you think about liver enzymes, ALT is going to be more sensitive and specific to the liver. The way I remember that is L is for liver, or a liver test. That's a quick way to work around that. So ALT is normal, bilirubin is normal. So this ALK phos elevation is probably bone, which unfortunately in her case ended up being metastatic breast cancer. So you guys are probably like, why are you showing me lead kettle, PT Barnum and Bailey, and a bunch of M&Ms? And I'll tell you why. Because if you're into mnemonics, this is kind of a way. I don't know if you guys are into mnemonics, but I remember learning this 20 plus years ago when I was in PA school. But PBKTL, or lead kettle, PB being the chemical signal, or PT Barnum loves kids, and then or a lead kettle full of M&Ms. Just a bunch of reasons here, but these are the most common cancers that are going to metastasize to the bone. So prostate, breast, kidney, thyroid, lung, and then multiple myeloma. When prostate cancer, for some reason, when it goes to the bone, causes hypercalcemia, usually less than these other ones do. But in her case, she had metastatic breast cancer. That's why she was having the back pain. That's why the ALK phos was elevated. So what else causes hypercalcemia? Again, this is going to be on your handouts here, but 90% of your differential is going to be in the top 2. So if you see hypercalcemia, 9 times out of 10, it's either going to be the top one or the second one. And if the patient's sick and in the hospital, then it's probably going to be malignancy. So primary hyperparathyroidism, malignancy. If they're sick, it's probably malignancy. And then other things here, sarcoidosis, drugs, just 30 seconds on that. We, Mayo Clinic being kind of a referral center for the world, we get a lot of patients that are referred there and they're told, hey, you have cancer, go to Mayo Clinic, they're going to figure it out for you. And they're making that assumption because their patient's calcium is like 10.6, barely elevated. And so all we do is stop their hydrochlorothiazide and say that's the cause. And so a lot of times that happens. So just make sure when you look at the med list there, especially with a mild hypercalcemia. See, now I don't know why these all fell out of order. So I'm going to skip past that. So how do you fix or how do you manage hypercalcemia? And so when we look at, again, this slide breaks every single PowerPoint rule there is, small font, there's too much on there, but we'll go through real slow. So patients that show up with hypercalcemia, they're always going to be dehydrated, and it's a bad combination. So patients with hypercalcemia always need hydration. So start with hydration, give them saline, give them tons and tons of saline. And then if you can't give them saline anymore because they're starting to get short of breath, they're starting to get pleural effusions, give them a little bit of furosemide so you can give them more saline. The furosemide will help them pee out calcium, and then the fluids will help rinse things out. You don't want to give the furosemide first, though, because these patients, calcium is a diuretic. These patients are always going to be dehydrated. They're probably going to have an AKI. And if you dehydrate them further with hypercalcemia, you're going to get a kidney stone or things like that, and things are going to get much worse. So hydration first, always. Give them as much as you can. And then after you do that, you need to move the calcium around. So ways of doing that is bisphosphonates, calcitonin, furosemide. And so the things with bisphosphonates and calcitonin and furosemide, again, we talked about furosemide. Make sure that they're hydrated first before you give that furosemide. And then next, you want to use the calcitonin because that works fast. The thing is, calcitonin has what's called tachyphylaxis associated with it, which is a fantastic word if you're playing Scrabble, and you get that X on like the triple letter score there. But tachyphylaxis means that you cannot use the med repeatedly and still get the same effect. So you can't calcitonin your way out of a hypercalcemia crisis, is what I'm saying. A couple doses and some fluids, that'll help bring the calcium down so you can get the patient out of the hospital. But before they leave the hospital, you want to give a bisphosphonate. And typically we would use something like Zometa or Primidronate to do that. And what that will do is drive that calcium into the bone, for the next 6 weeks or so. By then you can get them follow up in oncology if that's the cause there. When you talk about hypercalcemia and when do you use steroids or prednisone, so that typically will work best in your patients that have lymphoma. And so lymphoma patients have like this vitamin D analog in their gut that increases their calcium absorption. So if you know it's hypercalcemia from lymphoma, these patients will respond to prednisone 60 times about 5 days. Denosumab is one of these monoclonals. So I feel like they're developing monoclonals for pretty much everything. So right now, it's not approved in the United States until we've, proven reasons why they can't get, a bisphosphonate or something like that. So, the bisphosphonate isn't working. They have renal failure. They're getting osteonecrosis of the jaw. Those are all indications to use denosumab. Every time I give this presentation, people always say, hey, I'm going to check a ionize. So what does that mean? And again, this is back to like plasma and serum potassium 4. Just pick one that you're comfortable with and stick with it. Don't bounce back and forth between calcium albumin combination and an ionized calcium. Remember, if you're checking the serum calcium, you need to correct for the albumin. And so in her case, if we would have worried about correcting for the albumin, we would have wasted time, right? Because her albumin, I guarantee you, would have been low because she was hypercatabolic from the malignancy, and that calcium, which she was already symptomatic for, would have just corrected higher. So the albumin wouldn't have mattered on her. But when you're trying to assess response to treatment and things like that, that's where it's going to be helpful. If you're going to get an albumin, remember that albumin's half-life is like 2 to 4 weeks, and so you don't need to get an albumin every single day. Also remember, albumin is an inverse acute phase reactant. So when we're sick, albumin goes down, which stinks physiologically because we could really use the oncotic pressure, especially our hospitalized patients. So sick patients, their albumin will probably be lower, and then it's going to bring that calcium down with them as well. If you're checking an ionized calcium, just know it's going to cost a little bit more. And if the patient's pH is jumping around, it's going to bump the results as well. There's a couple studies out there for calciphylaxis where a dialysis center only used ionized calciums, and they missed a whole bunch of calciphylaxis diagnoses. So I typically will check a serum calcium and an albumin on day 1, and then use that albumin to correct the rest of the way. And then once they're asymptomatic from the calcium, then they can go outpatient and get the workup that they need. All right. So sorry, some of those questions had fallen off. So here's Mr. Sweaty. Here's our last patient. This guy's pretty sick. So he's diabetic, chronic kidney disease. He's had his appendix removed. He's single, drinks a lot of alcohol, smokes a lot of cigarettes. He's on some diabetes meds, some cardiac meds, aspirin, metoprolol, Norvasc. He's nauseous, he's vomiting, he's losing weight, and he's real sweaty. So he shows up in our emergency room with some pretty nasty labs. He's pancytopenic, he's hyponatremic, he's hyperkalemic, His creatinine is up through the roof. His LDH is up. His phosphorus is high. His calcium is low. His uric acid's pretty darn high as well. So sick guy in the ER, young guy actually. He was an Indian gentleman, about 44 years old. And again, the labs fell off here. So the question is, what is this, or what is he presenting with? And this is tumor lysis syndrome. So unfortunately, this gentleman had progressed Hodgkin's lymphoma that had outgrown his blood supply. Is such fast growing that he had gone into tumor lysis syndrome. So if you look at these labs, things that would make you think or at least worry about malignancy or something like a blood cancer would be the pancytopenia on presentation, and then all the electrolyte derangements. So tumor lysis syndrome obviously is life-threatening and needs to be managed appropriately. These slides here are all the handouts and how to take a look at that. Why is tumor lysis syndrome an emergency? The hyperuricemia, uric acid can crystallize in the renal tubules and lead to acute renal failure, which he had already had. The hyperkalemia, we had just talked about that with Mr. Farmer, and then the hyperphosphatemia ends up dropping the calcium, which can be symptomatic as well. So here's his admit labs again. So pancytopenia, hyponatremia, hyperkalemia, and the list goes on there. My question is, how do you then manage this? All the questions fell off there too. Okay, so how do we manage this? So fluids. In hospital medicine, or at least in where I'm working, we co-manage with hematology inpatient patients. So we'll get a lot of these tumor lysis managements as well. And a lot of times you'll be out in front of them. So with tumor lysis, if you know it's coming, you can treat those patients with allopurinol and get ahead of that. But in this patient, we didn't have that kind of warning. The patient had already had gone into tumor lysis. And so you cannot use allopurinol there. And so the first thing on a lot of these patients is IV fluids, and then something like rasburicase, which is what we would use to then kind of dissolve the uric acid that's there, and then manage the hyperkalemia. When you talk about, management, when we talk about the things that you need to do, obviously renal insufficiency, we need to correct with IV fluids. The hyperuricemia, like we had talked about, again, patient has a new lymphoma, slow growing, not in tumor lysis syndrome. You start allopurinol, knowing that we're going to start induction chemotherapy in a little bit. So we're going to decrease that uric acid load. Unfortunately, when they show up, which the American value is 7.5, and I think you guys are like 60 times that, so it'd be like 45 or 450 or something like that. Once you get above that threshold of uric acid, it's too late where the allopurinol is not going to work anymore. And so those patients need a dose of rasburicase, which is super expensive. You want to make sure, one, they're not pregnant, and two, that they don't have G6PD deficiency. But that rasburicase then will drop that uric acid down, so you don't have to worry about that electrolyte as well. If you want to see how you're doing with the uric acid management, when you draw that uric acid or that repeat uric acid, you want to make sure that that tube is placed on ice. Reason being is because the uric acid or the rasburicase will continue to work if the tube stays at room temperature. So by the time it makes it to your lab, it'll give you a false representation as to how well you're doing on managing the uric acid. So uric acid draw, place it on ice. That'll tell you exactly what the uric acid level is at the time you gave the rasburicase. And then the hyperphosphatemia, typically what we do is just use some phosphate binders for that. So you want to bring that potassium down, or that phosphorus down, with something like Foslo. Hyperkalemia, we just talked about managing with Mr. Farmer, all the strategies to do that. And then the hypocalcemia, a lot of times with tumor lysis, that draws your attention. So you're looking at all these lab abnormalities and you see the calcium. If the calcium is low, that's what we expect actually, because the phosphorus is up so high from all of the lysis of cells. And so actually you don't need to intervene on hypocalcemia unless the patient's symptomatic. So they're having seizures, they're having tetany, things like that. Otherwise, if you just treat the phosphorus first, that'll actually bring the calcium back up. All right. So I apologize, all the audience response fell off of the last couple of cases, so it made it a little bit herky-jerky. But as far as running the list here, these are the patients we took care of today. So Mr. Millennial, he was our hyponatremia, and the take-home points on him. So when they show up, you want to know what's their volume, or what's their serum osmo. So a lot of times it's going to be low serum osmo, hypotonic hyponatremia. What I forgot to mention is if you have a high serum osmo, so the patient comes in with hyponatremia and their serum osmo is like 310 or something like that. That's actually as far as the workup goes, it's quite helpful because it narrows down your differential very fast to at least 3 things. The only thing that can cause a high serum osmo with hyponatremia would be hyperglycemia, hyperparaproteinemia, so multiple myeloma, or hypertriglyceridemia. So the patient has familial hypercholesterolemia or something like that. And so most of the time, the patient's going to have a low serum osmo, low serum sodium. Then the next thing you want to look at is what's their volume status. So are they telling me that they're dry or they're dehydrated? Does the history fit with that? Are they tachycardic? Are they hypotensive? Those patients are probably going to benefit from saline. And remember, we can give them a lot of saline, but we want to go slow if they're okay. If they're seizing, obviously, we're going to need to adjust and use some 3% or something like that. But the tough ones are the ones that show up with a low serum osmo, they're euvolemic on exam, their vital signs are stable. I would just urge you to just hang on a little bit and wait before you intervene. Just grab a spot urine sodium. If the spot urine sodium is low, then you can be pretty comfortable giving the saline. Because as you remember, if your serum sodium is low, your body should say, hey, don't pee out salt. We need as much salt as we can get. And so a low urine sodium would correlate with dehydration. High urine sodium, SIADH, then we fluid restrict less than 1 liter a day. That sodium should start to come back up. Mrs. Salty, she was our patient. Again, if you're seeing these big chloride swings, especially somebody outpatient, pretty hard to get your chloride up to 120 sitting at home. And so think before we intervene. So the patient didn't need a transfusion, didn't need an EJD, probably didn't even need admission to the hospital. And so remember, if the patient has a peripheral IV and the phlebotomist who's trying to draw 50, patients' blood because they're the only one working the shift and everybody else had quit and people are yelling at them and they accidentally draw upstream from that, you're going to mix whatever's going into that IV into the hand, into the anacubital draw, and then that's going to throw your results off, especially if it's normal saline. Mr. Farmer, he's our hyperkalemia patient. So patient comes in, potassium, anything above 6.5 is probably going to start changing your EKG. So once you see EKG changes, you use calcium to stabilize. Calcium carbonate, calcium gluconate, whatever you can get your hands on. That's going to buy you time. It's not going to correct the potassium at all. It's just going to give you more time to do something about it. Then we can use things like insulin and D50 and albuterol. The albuterol, take it easy if the patient has an ischemic threshold that's low or they have coronary artery disease or they've had 50 stents placed, just skip that. Just go with the insulin and D50. If you have access to dialysis or if they're already on hemodialysis, do dialysis. Don't temporize because then you've just delayed when they can get dialysis 6 hours. Mrs. Khaleesi, she's our hypercalcemia. So first line every single time is to hydrate these patients. They're always dehydrated. You're never going to go wrong with giving them normal saline. So give them normal saline. If they start to get a little congested or short of breath, give them furosemide. That's going to actually help pull calcium off and it's going to allow you to give more fluids. Once you've gotten that calcium down or stabilized with fluids, then you use something like calcitonin. It's expensive. Remember, you can't calcitonin your way out of hypercalcemia. A couple doses, then it's not going to work anymore. But that's also going to help bring down that calcium. Once you get that down, the patient will start to wake up. They'll start pooping. They'll start feeling better. Then you hit them. If you know it's malignancy, you can give them a bisphosphonate prior to going home. And when you compare the bisphosphonates, or at least the IV or the ones that we give in the hospital, Zometa has outperformed pamidronate with hypercalcemia of malignancy. So we tend to grab Zometa rather than pamidronate. Just remember, if it's a lymphoma hypercalcemia, that steroids are indicated there. And then just remember, if they get into trouble where they start getting osteonecrosis of the jaw or their creatinine starts to climb, you do have a monoclonal you can grab, but again, super expensive. And then Mr. Sweaty was our spontaneous Hodgkin's lymphoma. Once you outgrow that blood supply and you start having cell turnover and death and breaking cells open, it's an emergency. And the electrolytes all come flying in and they're pancytopenic and they're sick and it's overwhelming at first. But if you remember just kind of managing things, obviously we want to hydrate these patients. They're always going to benefit from fluids. And then we want to make sure the hypercalcemia or the hyperkalemia doesn't cause any cardiac stuff. So we want to manage that. When it comes to the uric acid management, again, if we're out in front of it, we can use allopurinol, but if we get behind, then we have this drug called rasburicase that we can use. It's an enzyme that helps with uric acid degradation. It's super expensive. We want to make sure the patient's not pregnant or has G6PD deficiency. And then we want to treat the phosphorus with Foslow and then let the calcium come up on its own, unless the patient's seizing from hypocalcemia. So super fast, went through a lot of electrolytes. A couple of my audience response either I screwed up or something happened in the flight from Minneapolis. But thanks for hanging in there with me. I don't want to take up any lunch time, but I'm here to answer any questions. I know there might be some virtually as well, but I can answer questions over there or wherever they want me to answer questions. But I appreciate you guys hanging in there with me. So hopefully it's helpful. Thank you. I'm doing a similar presentation and I'll make sure that all the audience response are right on platelets, same style after lunch. What's that? Do you want me to take them down here? So that, yeah. Yeah. Yeah, no problem. Yeah. Yeah, that's a great question. So it depends on kind of the level. So with our gentleman that was 103 that was just walking around, we were correcting him, but we were still nervous. So we were drawing it like every 4 hours to see where we were at there. The thing is, and if we're seeing it at Mayo, which we're again spoiled because we get a lot of donations, you know, from benefactors and stuff where it's kind of a protected hospital environment, but we just don't have a staff. And so we may order it for every 4 hours, but we were not getting the phlebotomists up to the floor to draw them and then the lab techs because everyone's short staffed. So you want to, you know, make sure you have room for error there. But I would want to take a peek at it, at least on the front end when you're trying to correct it, when they're at highest risk for seizing every 4 and make sure you know where you're at. And then once you kind of start to stabilize or get above that 120, then I start to kind of spread them out a little bit more. And then you don't need to get the electrolyte panel every single time either. You can kind of save the cost and all that other stuff. The sodium should stay consistent if you just get a stat sodium. Yeah. Good question. Yeah. You only get one. Yeah, no, that's a great question. So the comment I made about like the calciums of like 10.4 or sorry, I'm probably saying the American values, but like I start to get nervous when the history scares me a little bit more than the lab test. Every now and then you might maybe see an elevated calcium and, you know, it could be dehydration or something like that. But if they start saying, hey, my pants don't fit anymore and I smoke 50 packs a day and I'm drinking all the time and my dad and my mom and everybody's had colon cancer or something like that, or breast cancer, something like that, that triggers it more than just the lab test. If somebody comes into the hospital with new onset like confusion and a calcium of 14, for sure, I don't care what the history is, we'll do the malignancy workup right then and there. But if it's just a smoldering low calcium, like in the just barely above average, unless the history worries me, that's when I would start to do that. Yep. Isolated hyperphosphatemia. Oh yeah, that's tough. I don't see a lot of that. What clinical context are you seeing that in? Right. Yeah, that's a good question. I guess I probably wouldn't do much with that other than recheck or keep an eye on things. But yeah, I don't see a ton of isolated hyperphosphatemia. I mean, if it's persistent, if it's one lab draw, I probably wouldn't intervene. I'd say, hey, let's check it again. But if it's consistent and persistent, then yeah, you have to probably start working up some renal issues and things like that. Yeah. Yeah. All right. Yeah, thanks.